get started with our integrated care solutions panel. And I'm going to introduce Nick Vizaka. He's going to move the panel along here. So thanks, Nick.
Thank you, Craig. So our panel's making their way up here. And as they do, a lot of the things that we'll cover have obviously been touched upon in the previous panels, and you'll see some familiar faces up here. But really, integrated care solutions to, explore opportunities, how to make things seamless, communication gaps. We had a pre-panel meeting and this is what we heard. We heard there's a lot of lack of communication, fundamentals, data, things that you've heard in the previous panels. So as we get kicked off, I think everybody has seen Kristen a couple of times today, but if everyone could just take a couple minutes and just introduce yourself so everybody can knows who you are. Go ahead, Matt, if you want to start. There you go.
I think we're good now. Yeah. Good afternoon, everyone. Hopefully we won't hit a post-lunch lull for you all here. But my name is Matt Mucci. I work at the UPMC Center for Social Impact. A lot of my work is focused on really serving our members and addressing social determinants of health, specifically better serving our members with intellectual disabilities and autism. And so I'll turn it over to John, and really I work to support a lot of the efforts that John has stood up over his career.
Afternoon, I'm John Lovelace. I'm the president of government programs at UPMC and the president of UPMC for You. I've been engaged in the IDD business since my supports coordination days, 25 or 30 years ago, I guess, long time ago, with Nancy Murray in the trenches, and looking forward to having a good discussion today and hearing Kristen for the 14th time.
Good afternoon, everybody. My name is Greg Chirpus. I'm the medical director for the Office of Developmental Programs. So I hear Kristen more than 14 times, and I'm happy to be here. I'm a psychiatrist by training, but in my role at ODP really focus on both the physical and behavioral health needs of our stakeholders, as well as focus on wellness.
Pass.
There you go.
Hello, everyone. I'm Scott Bachik. I'm the CEO of the BI Collaborative. We are a data analytics and business intelligence company that works specifically in human services. So we work with providers to help organize their data and use that data to manage the organization.
So thank you all for agreeing to be on this panel. And as we talked earlier in the week, one of the questions that came up, or one of the discussion topics was, and I had to write this down because I forget things, but was around quality metrics and for IDD. And the question was, should those be separate and distinct from one another, or should they correlate directly with ODP services, or be based on overall health and wellness? And just wanted to start that off and get everybody's thoughts on that. Should they be distinct?
Well, let me take a crack at this. I think
John.
they should be both, actually. There should be some common metrics around health that affect everybody. Your BMI, your diabetes status, your mental wellness, your state of anxiety, that sort of thing. But there are probably some special measures that apply particularly to people with IDD in terms of their role in life, their living situation, how they have different assets and different needs than in some cases than people who don't have IDD. So I think you'd want to look for a combination of standard metrics that go across all populations, and then specific metrics for people with specific conditions, not just IDD, but some other things of the sort as well.
I would agree with that wholeheartedly, that both specific and general measures, and in fact, I think probably more so the general measures in terms of the moving towards health equity for individuals with IDA. We know in lessons learned from the pandemic that folks with intellectual disabilities did very poorly. And there's a number of reasons for that may contribute from the intellectual disabilities. But I think the fundamental concern is that folks with intellectual disabilities and autism are living day to day at a disadvantage due to health equity concerns. So I think ensuring those that are on par with the general population, but then also, as John was saying, bringing in sort of specific measures as well.
One of the things I think has changed through the pandemic really is access to healthcare is not very good before, and really a low point in the pandemic, and it's still not very good. the timeliness of getting a primary care appointment, of getting anything out of an emergency room is long waits. And you don't know necessarily who you're going to get. The idea around the stat idea around people who have specialized knowledge about the evaluation and treatment of people with IDD is something we could apply to a larger range of providers. Part of my responsibility currently is also the community health choices program. So I oversee Medicaid, regular Medicaid and physical health, community health choices. I'm still connected with community care, which is behavioral health. So I have the opportunity to see this from lots of perspectives. And one of our challenges, I was going to mention this to Christian when I got up here in public, is we don't really know who has IDD. We know in Allegheny, we know who's in waivers because we have a data sharing agreement with Allegheny County. So we know who's in waivers. That's not as important as knowing who's on the waiting list or who isn't on the waiting, who nobody knows, of course. But the opportunity to coordinate efforts around access to care and outcome of care for people with IDD would be enhanced if we knew who we were talking about, and we don't. But we will.
So I think that's a great point, John, because you brought that up when we had our pre-call, and something that Scott had said during that is to get back to fundamentals. And how do we get back to doing what we should all be doing, right? And get back to the basics. So I don't know if you wanted to expand on that based on what, John's point on the quality metrics. You want to collect this information, but sometimes we don't even know who it is. So incorporating data into that and getting back to the fundamentals, how do you see that working?
Yeah, I think when I think about it, it's multi-tiered. So as John mentioned on the call, when you have the health information exchange and you're looking at claims data and you have the IDD claims data and physical health claims data, you can pull that together and you can get an overview of services provided, and you can give certain quality measures, readmissions, certain health tracking, like your annual physical. Those things can be tracked through that. But there's a whole nother level of quality that is much more complex, that gets documented and used through the EHR. And those are, I think, a whole nother dimension of quality where you're looking at fatal five, tracking bowel movements, tracking calorie intakes. That whole piece of it is an extremely important part of quality and needs to be integrated in. But that's at another level. And then to the discussion the other day, we have a long ways to go as an industry, as a human service industry, one in the context of EHRs. And I don't want to digress because I know we have the questions I don't want to get too far ahead.
No, please.
But we have a long ways to go with the adoption of EHRs. We have a ways to go with, I'm going to say, pressuring the EHR companies to be more interoperable, meaning some of them, we have EHRs in our state today that you can't get to the data unless it's a manual process. That doesn't serve this long-term vision of where we're going well. So I think that all needs to be worked through.
Yeah, and we talked about the EHRs and how many there are. And there's so many disparate EHRs that 10, 12, 15, but could they become cost prohibitive, right? In this industry, when you're asking some of these smaller organizations to connect to an EHR, a larger EHR, there's no money. So how do you address, that aspect of it?
One of the things we've been doing with some IDD partners actually is having some contractual arrangements in which we are paying IDD support coordinators, care managers, providers to upload data from their perception of their people they're serving into the EHR that we use. So the key to this is not how many EHRs you have. It's really interoperability. You don't have, everybody has their own system and they have to connect to each other to make any sense of this. Everybody can't have everything. So that process of uploading data from providers around IDD members has been really valuable in sort of assessing quality metrics, like people who have open gaps in care. They haven't had immunizations. They haven't had their wellness shot, haven't had their flu shot. Since we don't know who is IDD generally, we don't know what their status is. Using this connection with providers gives an opportunity contractually to let providers access the health plans, the EHR, not the health systems, health plans, the EHR, so they can, I think, read, but they can't write. No, they can write, and they can't read. They write in it. They only can see the people they're officially connected to. Matt could tell you more about this.
Yeah, and I think it's a really great point in that maybe you don't need to necessarily have a unique EHR, and each managed care organization might be operating off of a different system. If we're using Epic, maybe that's not the same across the totality of managed care in Pennsylvania. And so I think when you talk about becoming cost prohibitive, interoperability is definitely a large consideration. But speaking to the kind of program that we've set up at UPMC, and to John's larger point, really we have back-end data that you as providers can utilize once we open up that dialogue, once we start the conversation regarding our mutual membership. And so from a data perspective, I'd be remiss, Mary and Brenda, your teams have been really valuable to us in facilitating that baseline data exchange. And so for the first time, once we were able to see who our members were, really we were able to access what types of underlying issues exist within our members with intellectual disabilities in Allegheny County. Are they attached to a provider? Which residential providers are they attached to? And so from there, we were able to start discussions with some of the larger providers in terms of mutual membership, and really started to coordinate care and kind of start these monthly case conference calls where we're focusing on really preventative care versus that prescriptive after situations arise kind of care where folks are being seen in acute care centers in the hospitals. And so we're focusing on really closing gaps, making sure that folks are seeing their PCP on an annual basis, looking at medication adherence. Are individuals filling the scripts that they need to be filling? And we've shown a really great propensity to close a lot of these HEDIS gaps, reduce readmissions through some of these low touch points, such as monthly case conferences where we have care management staff. We have a medical director that coordinate with the medical staff at ID providers. And so through these case conferences and kind of working behind the scenes in between these sessions, we've been able to show a great propensity to kind of improve healthcare as well as hopefully increase access into the health plan, providing a single point of contact and so on and so forth.
And I think that the point that you just raised is so important, that step of the coordination of care, because all of the metrics that we're talking about are ultimately meaningless unless action is taken behind them. So sort of without that additional step, healthcare isn't going to move forward. So that's really great to hear.
I think having lived this every day, there's a lot of thought that you have to put to standardization of processes of how you enter that data into the EHR so you can do some of the things that we're talking about. And there isn't a provider that we work with that doesn't struggle with that. Just simple things of entering appointments into the EHR, how appointments entered in to be scheduled, and then was it rescheduled, was it canceled, then was it completed, and then how do you use that data to then target when the next appointment should be. So as you think about these things, that kind of quality assurance overview of how do you put data in the EHR consistently across your enterprise, and the larger you are, the more complex that gets. But that data is the foundational piece as we move forward, because without that, you not to diminish work, but you're instead of working one-on-one, you're working and looking at aggregated data to understand where you're strong or weak as an organization, and then helps you focus on where you need to improve, whether that's education, whether that's policy. So it goes back to kind of the tactical frontline work that needs to be done. And that's a heavy lift. That's a heavy lift.
I think the other thing I'd add to the conversation is I think for the Commonwealth through Office of Medical Assistance programs, we have what is called P3N. Don't ask me what that stands for. I have no idea. But it is the sort of clearinghouse where all of the health information exchanges in the Commonwealth, all of the data comes in to P3N. Internally at ODP, we have access to P3N, and we can go in and see people's records. Our HICUs have access to that. And one of the things that I think is going to help bridge some of these gaps for people enrolled, so who are at least known to ODP, which is only about a quarter of the population with IDD. But at least for that population, we have for enterprise case management at some point, it won't be in phase 1, but there will be some ability to connect with P3N in enterprise case management. So I think a lot of the groundwork for some of those data exchange that are going to be really critical in terms of integrating and coordinating care. We've got some, I think we've got some hope on the horizon in terms of a little bit better access to that for people who are involved in those care coordination meetings.
A lot of the health oriented care management work happens in health plans. Now, there is no equivalent office in the state, in the Commonwealth. So it's really an opportunity to think about how to, as a provider of IDD services or a sports coordinator, how to interact with people who actually are responsible for coordinating what care you get, where you go next. It's mostly the transitions that are hard. Yeah, accessing care is hard, but transitions are harder. When you move from this level to that level, the handoffs are not always very good. The receiving agency doesn't always know what the referring agency, they hardly ever know everything they know, but key things. So the opportunity to facilitate those transitions is another way to address health equity. This is an equity issue, among other things. It's a quality issue as well. It's an opportunity to sort of affect both those things in a more positive way, I think. And we've seen some nice results in our pilot work, and I think we see more as we get better at this.
And I'll take us back to selected contracting because no conversation today will be complete without that. To note that, and I don't actually recall what the 3 questions are, so hopefully I'm not preempting any.
You're good.
I'm good.
You're good.
Okay. That one of the metrics that we're working on is around the integration of care for people with complex needs. And you will see that the way that the performance measure is shaping up is this is one of the reporting measures, is what is, as a residential provider, what is your relationship with behavioral health outpatient providers, with physical health providers? And some level of discreteness. And do you have any kind of formal agreements? Do you have memorandum of understanding? If you are a provider that does both, what is your relationship? And does that give you greater access to some alternative or modified therapies so that people have access to that specialized care? And obviously we will have to do some work really defining that, but to sort of connect it back to, I mean, I think this is one of the lessons that we're learning from the START pilot very early on is when we were doing the gap analysis here in Allegheny County, one of the things that UNH, University of New Hampshire, really hammers on is you have to have relationships with these partners that are critical for supporting people to make sure that, you know, they're getting both the treatment and the support that they need. And so we've kind of taken some of that. You'll see that showing up in that performance measure. Again, we're not at a final stage of it, but that's what that means is, have you contemplated this? Do you have these relationships? What are they? What do they look like? How formalized are they?
Yeah, I mean, I think that's a great comment because I've sat on a work group on the east side of the state. And when we talked about linking the continuum of care from provider to provider, and I have a lot of physical health background, we always hand the provider. And there was a lot of work, like orthopedics of point rehab in the PCP and in the surgeon and in the hospital and having discussions on the coordination of that care. That's a struggle here, but it's critical that be addressed. And then, on the physical health, there was reimbursement models like bundled payments that facilitated that. And then there were organizational structures like accountable care organizations that help create that oversight to help facilitate that. But as we look at this integrated care, physical health with where IDD services, I think it's so important, but it's so hard specifically for smaller providers to approach that.
I think really an opportunity to think about, there are really many points of integration, but there's physical health, behavioral health, and then there's the IDD system. None of them really they don't speak the same language generally. They don't talk to each other generally. Sometimes people do it around a particular person, not very often, but it can happen. But so they operate sort of in independent spheres doing their own thing without really even knowing what's happening to other people. So a lot of opportunity to think about how you use EHRs and other kinds of communication methods to identify who's doing what to whom when, or at least who did what to somebody yesterday. So you get a little ahead of the game.
Go ahead.
I was gonna say in two pieces. It's both the data, right, to understand even what the picture is, but it is also that care coordination so that we get out of this, well, that's the system that this happens in, and this is the system that happens in. Bundling helps get rid of that question, but it doesn't really get rid of the question unless you've got really good care coordination that is looking at a person holistically. And I think that's often a struggle, no matter what the sort of payment arrangements are, is the two of those working in concert with each other.
And I was just going to echo, think about how important that is with social determinants of health, and think about the redundancy of efforts for each of those providers doing the assessment to determine if an individual has a social determinant, and then the coordination of getting that individual the right services or help. There's a lot of redundant effort that's going on because that doesn't exist today.
Well, I think that's a buzzword or a buzz phrase, Scott, social determinants of health. And I think I'd like to get Matt's input on this, given your role. A lot of data is starting to be collected, particularly on the acute care side. But how do you address that here in the IDA world, social determinants of health, and really collect it and analyze it and make it actionable? John likes the microphone. He does not like giving it up. He wants.
We can pass it back to him here in a second here, but I think that what you were saying, Scott, is really a good insight in terms of, I think there are so many touch points here where you're talking about redundancy, and how many times are we going to ask the same questions to the same person and not make them apathetic towards what's really going on there. So I think it really boils down to all of these relationships and being able to streamline a lot of this data amongst all of the different stakeholders in a person's life, and be able to coordinate around that. And so I think that when you're talking about something like a managed care organization, we do have a lot of claims-based data that is valuable. We have a lot of resources built out, specifically on the social determinant side, where we have a lot of different connections and resource and referrals that we can make, but also want to respect the fact that that exists pretty much across the entirety of the system. And so without open communication and dialogue, I think that you're going to continue to run up against this redundancy that unfortunately mires the system in a lot of ways.
Well, you talked earlier this morning about HRSTs, HRCTs, whatever the right word is, the health risk assessments anyway. The health plans do health risk assessments, providers do health risk assessments, is to Matt's point. We don't have to keep doing them over and over again. If we were a little better sharing, we wouldn't, and timely about sharing, we wouldn't have to keep asking people the same question over and over again, especially questions that don't have answers. I was on a call yesterday with some folks who are advocating for some CMS changes in terms of billing for screenings for social determinants of health. And the proposed rule is the CMS will pay you to do that in Medicare, but pay you to do that if it's tied to an E&M code. So if you have a diagnosis for something, then they'll pay you to ask for social determinants of health, and then you get to pay a copayment for that. So people aren't going to want to do that probably. The opportunity to think about how to, but maybe whatever RISE PA is called now, that's under their name, I think, the statewide social service referral system. Well, maybe it's an opportunity, if it goes well, to facilitate this process around, we don't have to have 9 people asking the same person the same thing 9 times, with maybe nobody actually helping anybody, but be able to see what happens to those referrals and do people's needs get met differently. Certainly your health status is affected by your nutritional status, which is affected by how much you can afford to buy and what you buy. And that's true of where you live, what you buy, that has much more to do with your health outcome than what your healthcare is, as you all know. So that's there's certainly a lot of opportunity for improvement here around the coordination of care. And if we get through the constraints of confidentiality, which are many, and think about how to do this more in organized fashion, the confidentiality, of course, is important to many people for lots of reasons, but it also is a great hindrance to getting anything actually done. So we have to figure out a better way to through that maze, I think.
Real quick, completely agree. I think those are very real and significant hurdles, but it's incumbent upon us to figure out how to do that. We are. I do believe that we actually have a meeting scheduled or is being scheduled to be discussing the data exchange. So just I know a request came through very recently, so I do think we'll be having that discussion soon. Yes.
Yeah.
It's certainly been really instructive in our demonstration with Allegheny County, where we have for lots of other reasons, they have a very robust data warehouse that most people don't have to start with. And they have very skilled people in terms of extracting things. So we have regular file exchanges. So they know what people's physical health is happening, and we know what's happening in the social service side. So you have a better sense of, is what we're doing in terms of healthcare coverage. If people are staying out of the hospital because they're in jail, that's not really a good thing. But all we know is they're not in the hospital. We don't know people are in jail except unless somebody tells us. That these kind of exchanges help know what else is happening in someone's life that influences what you're trying to do, whether it helps or hinders it.
This is part of the elephant in the room part. Like, as we think about these, we'll say high level strategic alignments of this information and data, the big question is, how do we then, does that get down to the provider? The average IT staff and a provider is 1 or 2 people. So having the capability to integrate into some of these data exchanges or get that information, disseminate that and make it digestible just isn't there today. So there has to be somewhere in this infrastructure, a level that helps the provider do that, because it's useless if we can't get it in the hands of the people that are delivering the services.
I think one of the interesting things we talked about too, and I just thought about this, spending most of my career in the acute care world, as you read the news today and you see stories out there, a lot of solutions, particularly in healthcare and particularly in this room, chances are the solutions to these problems maybe will not come from people in this room. They'll come from outside industries looking in, where that two unlike industries, when they intersect, that's where innovation happens. So are there things out there in other industries or other systems that we know of that we could leverage or at least look at and think, I hate the term outside the box, but think differently? Is there anything out there that any of you could think of?
Well, I think one thing that comes to mind is artificial intelligence and how it will have capacity to gather data from lots of places and synthesize it to something which could, of course, be completely wrong. But it might be, the gathering part still takes some interpretation. I think that's one tool we've not done much with in terms of HC4 data and P3N data and we have lots and lots of data. CMS has lots and lots of data around Medicare, and there's just different ways to use it than what we're using now, I think. And looking forward is a little harder. Looking backwards is a little easier, I think.
And I agree regarding artificial intelligence. Obviously, there's a lot of progress that needs to occur with the implementation. Where I see it being potentially effective in the lives of folks with IDA is to address the very real condition of physician and healthcare provider bias about the quality of life issues for persons with IDA. If we have artificial intelligence contributing to care decisions that aren't based on those biases, actually, I think we can push healthcare forward for folks with IDA.
Yeah, I mean, I would echo that. I mean, Chris and I talked a little bit before coming up here. That is one of the most exciting things ever is AI, and there are multiple versions of it. There's large language models, there's cognitive, there's predictive, right? So understanding that technology and how that can be used can serve us in a lot of different ways. I think as we are able to aggregate some of this information about the individuals that we serve, to understand algorithms to help prevent things from happening, to help facilitate protocols of best practice, That's all on the horizon. I'm not aware of anybody that's doing it today. We're in discussions about doing it. We're looking at how do we leverage data from ISPs to be able to help in that, but we're very much in the infancy of that. But it's a super exciting time.
I want to give time, Patrick, obviously, for questions. If anybody has any questions for this panel. Anybody out there with questions or comments on what you've heard? Ideas? I know everybody, it's like Thanksgiving dinner. Everybody ate lunch and now they're like, you shouldn't have given dessert till now. Go ahead. No, you're good.
Thanks. I think this is a great discussion. And as someone who I think is prone to oversimplify things, I just wonder, my approach to this has been sort of as an individual user and seeing the power of the UPMC health plan app in my case. So there is a lot of data there. And I know one of the questions that arises is, well, how do you sort through that? I think the artificial intelligence discussion is really interesting. I heard a similar discussion the other day. Artificial intelligence will give you an answer. It won't necessarily be the right answer, but it will give you an answer. But where do you see the care coordination piece? It seems to me if you could get commonality in a database and everything was where it needed to be, a care coordinator that didn't exist in the individual service areas of IDA, behavioral health, and physical health, that seems to be the key thing. And I'm not sure if we have that or not. Like, I think the overall intent was, and it's come up a couple of times, could somebody doing care coordination access the data from the app on an as needed basis? And are we any closer to doing that? Or is that in the thinking when we talk about integrated care, that care coordinators don't necessarily exist the way we think about it in supports coordination and IDA, but care coordination across all three of those domains?
I think one of the great opportunities actually in terms of at least our apps, and I'm sure it's other apps are similar, people who have authorization to access them. It doesn't have to be the patient in emergency health. It could be a supports coordinator or their parent or some sort of advocate who has access to information about what. There's all kinds, as you know, there's all kinds of stuff. All your lab bills are there. I don't know what they mean, but they're all there. You see every lab test, every X-ray, every image, every opinion, every specialist ever wrote. All the next appointments, last appointments, claims paid, what isn't paid. It's accessible to the individual who's enrolled now, but it could be accessible to other people in a way that's more systematic. Assuming you take care of the confidentiality issues, which is really the individual person's decision. I want this person or this organization to act on my behalf. I think that's certainly a different way to access this vast array of information that happens. It doesn't include behavioral health particularly, but that's another confidentiality problem to deal with.
I think it's Dick's comment of don't think, look. I referenced accountable care organizations in physical health. I think there needs to be an administrative entity to be able to manage this across those. We're in discussions with a group out of Minnesota called Altair. They're an accountable care organization for IDD individuals, but they manage the whole person. So I think there has to be an entity that does that because of the lift and expertise that you would need from a technology standpoint, from a clinical standpoint, to help then disseminate that information to whoever's in your network, right? I don't think we can expect providers to do that today. The issue with that is that you add that piece in here, the margins are very tight. If Kristen would only raise the rates, we could figure that out. But you know, if you put that entity in there, there's money there. So then how does that get paid for?
Well, sort of moves you into the larger conversation on value-based payments in general. There's lots of money. It's not spent very well. There are lots of ways to spend money better than the way we spend it. And it's driven by lots of things, including what's accessible, which is not necessarily what's not right, but it's accessible. You can always go to the ER. As my colleague says, especially if you're a Medicaid recipient, what do you have better for me than open all night? It's free. You get a ride there. You get a sandwich. You got coffee. Everything's done at once. You get all your labs, you get all your medicine, and you get a ride home. Something better than that 24/7? No, you don't. You have to call up, wait 3 months for an appointment. And then it gets sent to 5 other people. So we have lots of ways to organize things differently around how to pick what you pick in terms of services, how you access those services, and how you move from service to service. There's a lot of money could be redirected into more productive uses and in every system, not just in health. It's in every systems like this. Things tend to silt up at the top where all the money is, and that leaves big gaps at the bottom. And I spent my time in MHMR when it was called MHMR. Now it's BHIDD. That was then. That was that 30 years ago. It's not much different now, other than more money.
Any other questions, comments? So before we end, you know, we hear a lot and we want people to leave obviously on a positive note. And when you think about integrated care solutions, there's one thing or two things that each of you could leave this audience when we are talking about integration and coming together with solutions that folks could leave optimistic. What would that be? What would you say to everybody? I hope you say something, because if you say nothing, these people are going to leave really pissed off.
So I'm going to go first, just because one thing that has struck me, and I'm going to speak from a government standpoint, in the 8 years that I've been with ODP, from the beginning till now, and I think frankly pushed forward from the pandemic, I see a greater integration of resources and input across OMAP, ODP, and OMSAS. So these three offices are working together, to my impression, in ways that weren't happening before. So I think that, and that is instrumental. You know, all of the things that we're talking about really rely on improved efficiencies at that level, and I think that that's occurring. So I think that that's a very positive note.
Yeah. One of the things that always struck me as an interesting phenomenon of government. Mostly when I worked for the county, I noticed this. One of the keys to success in your division, whatever you're doing, I did mental health and drug and alcohol at the same time, was making your problem somebody else's problem. This is not really a drug problem, it's really a mental health problem because there's more money there, or it's really, as you know, there are lots of people with IDD in this community health choices program because it's accessible and IDD is not. So it's not probably the right service for most people, but it's a service, and families who need supports, you can get direct care workers in your house. They just don't know what they should know. They don't have the right skill set to do what they need to do necessarily. IDD people don't necessarily need help with homemaking and bathing. They need help with habilitation. So people move where the easiest thing to get is, because you need something. We have opportunity to think about ways to rationalize this more sensibly. So the services go where the people are, not the people have to go where the services are.
I would say on a positive note, one of the opportunities that the pandemic unfortunately gave us was really highlighting the health inequities. So I think, you know, you see signals from federal government, the American Medical Association, Dental Association. I think there is a newfound focus that I hope will continue. And I certainly know there's advocates in this room that will make sure that it is continued to be elevated as an issue. And I do think that gives some opportunities to really keep pushing and addressing this issue in terms of, you know, how we're looking at physician training, how we're looking at how we compensate, you know, through health plans, how that care is coordinated. I think at least there's more of a spotlight on people with IDD and how it's not been a population that's had great outcomes in our current health and behavioral health system. So I do think there's some great opportunity there.
Yeah, I mean, I think if I think back to physical health in the 90s, when we started linking care continuums, they were just discussions. There's a lot that you can accomplish by just getting the right people around the table and talk about providing services to individuals. So I would just promote that you don't wait for legislation or reimbursement models to drive it. Those are discussions that you can start. Again, using an orthopedic example, in the 90s, we were pulling people from different providers together to have that discussion to say, how do we make this more seamless? How do we serve these individuals better? That can be very, very powerful. It doesn't have to be, you know, written in law.
I'd really just echo those sentiments right there. And I think that in the long run, there are going to be advancements. There are going to be, EHR considerations. There are going to be a plethora of different ways in which technology affects the way that this system and system delivery is handled. But in the short term, I think there are ways to start doing this right now. There are conversations that can be had. There are relationships that can be formed. And those are the types of relationships that we're looking to facilitate. And we have data, and with I won't say little effort, there are lawyers involved in the process. It does take time, but when we do have the proper agreements in place to where we can start to exchange some of this data back and forth, we can start to address issues that really delve into areas of quality and ensuring that care is really provided to the right person at the right place at the right time. And so these don't necessarily have to be high cost options. And so we're always willing to have those conversations on the managed care health plan side of that kind of tripod. And so would encourage anybody who's interested in kind of looking at what it would look like to work with a health plan to reach out.
So I'll leave you with this. I think, working with Patrick over the last few months in our alliance and strategic relationship, and knowing several of the people in this room, I'm optimistic because the caring and dedication, when you put the people element along with what Dr. Chirpus said with the AI and the machine learning and what's coming on the tech side, everybody here should be extremely optimistic, and you should be extremely proud of what you do. And I think, Scott, really harnessing the power of data and that analytics to incorporate into that, and everybody working together really creates something special. And I think everybody in this room has the opportunity to do something special and be groundbreaking in that area. So I thank you all for everything you do, and thank you everybody out there. You should give yourselves a hand for everything you do and your staff every day. Thank you.